Hello, everyone. I am Dr. Mubin Syed, your Desidoc. Welcome to our program today in honor of South Asian Heritage Month. And today in our expert spotlight, I'll be talking to Dr. Venkat Narayan, who is, one second, I'm just gonna, who is, I had a whole introduction here. Sorry about that, Dr. Narayan. Okay, who is regarded as a national and international leader in diabetes and a member of the National Academy of Medicine, noted for his substantial multidisciplinary work in diabetes, clinical and public health sciences with 2 books and over 550 publications. His work has been cited over 185,000 times. He has spent a decade at the U.S. Centers for Disease Control and Prevention, leading science efforts in his role as Chief of Diabetes Epidemiology and Statistics Branch. His research has focused on the epidemiology of type 2 diabetes and on large national and international studies to prevent and control diabetes. Dr. Narayan also spent 4 years with the in the seminal Pima Indian study of diabetes, where he completed the first diet exercise intervention study in that population. He is currently also exploring pancreatic cell biology and intriguing differences in the pathophysiology of type 2 diabetes in Asian, African, and Native American developing country populations globally. He has served on the executive investigators committees of ACCORD, a multi-center randomized controlled trial of cardiovascular disease prevention amongst people with diabetes, and is an investigator in the DPP, a multi-center randomized controlled trial of lifestyle and metformin for diabetes prevention. Dr. Narayan is currently the executive director of the Emory Global Diabetes Research Center and the Ruth and O.C. Hubert Professor of Global Health and Epidemiology at Rollins School of Public Health and a professor of medicine and endocrinology at Emory University School of Medicine. Additionally, he serves on the committee of the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine. Thank you, Dr. Narayan, so much for being available, and we're really honored to have you here.
Thank you, Mubin. It's my pleasure.
So, Dr. Narayan, can you tell us, how you got started in this? What sort of thought process led you to be interested in this field, and specifically about South Asians?
Yeah, I mean, it's all been serendipity. I mean, I started my career as a physician, and I often say that I was a good doctor, but there was something missing, in terms of just being a clinical doctor.
Mm-hmm.
So somewhere along the way, after training in medicine as a medical resident, and I was thinking of going into gastroenterology, which is when I discovered a little book called Clinical Epidemiology by Fletcher and Fletcher. This was when I was in the UK. And then when I read that book, it was actually at 4 o'clock in the morning when I was on call that I sat and read that book. That book inspired me. It really, emphasized to me the importance of knowing the science behind clinical medicine. So that's what, gave me an interest in epidemiology. I pursued training in epidemiology in Scotland, became a faculty and consultant in Aberdeen. And then from there I was doing largely cardiovascular disease research. And one of my early papers that I wrote along with another colleague in Aberdeen described the mortality among people with diabetes. At that time, the fact that we reported that people with diabetes were dying of heart disease was a new finding. It was a relatively new finding in those days.
Yeah.
So then that one thing led to another. Somebody introduced me to the Cambridge diabetes research course, which was a 2-week summer program led by several leading investigators in diabetes. So I spent 2 weeks there, which was when we played games and we designed diabetes prevention trials. And then lo and behold, some weeks later, I get this wonderful invitation from Dr. Peter Bennett at the National Institutes of Health, asking if I wanted to spend time with the Pima Indians studying diabetes. So I resigned a tenured faculty and consultant position in Scotland, and we moved to the US with the NIH, and that's how my research interest in
Wow.
diabetes began, and this was in 1992. So for the
Yeah.
last 30 years, I've had the good fortune of being in national, international level diabetes research. And my interest in South Asian populations only started probably 10, 12 years ago after I
Okay.
moved to Emory University. Until then, I was largely, researching in other populations, Pima,
Huh.
blacks, white populations, the US,
Yeah.
Taiwanese, etc. Yeah.
Wow. Interesting. And that was quite a unique opportunity that you had to work with the Pima Indians. I've always, because we learned about that, of course, in medical school, and I always wondered about that. And you made some very interesting, unique discoveries for them, and also potentially the correlation with South Asians. Actually, before we go into that, I just want to ask you, can you tell us like about some of the statistics regarding diabetes in South Asians?
Yeah, let me complete that connection and then
Okay,
I'll
sure,
go
sure,
into
yeah.
it. So when I worked with the Pima Indians between 1992 and 96, the Pimas clearly even today have the highest rates of diabetes in the world, incidence in the world.
Yeah.
And at that time, yes, I had the opportunity of designing an intervention trial in the Pima Indians. But more importantly, in the 4 years I discovered, every time we would publish papers from the Pimas, reviewers often thought this was a Pima phenomenon, such high rates were Pima
Hmm.
phenomenons. So I would glibly ask the question, what if the rest of the world became Pimas? And
Yeah.
to me, that has always been in my head, in the idea that the Pimas were a sentinel population
Hmm.
where modernization or changes in lifestyle due to changes in economy disrupted a
Like the
very,
canary in the coal mine
yeah,
type
a
of thing.
canary in the coal mine, exactly. So
Yeah.
what if that is the case? And so anyway, coming back to your question of the statistics of diabetes in South Asia, I mean, when you think of South Asia as the Indian subcontinent, okay, so India alone currently is estimated to have about 77 million people with diabetes. That's
A huge
more than the
number.
size, yeah, huge number. Country the size of Britain plus more.
Yep.
And then you add Pakistan, Bangladesh, Sri Lanka,
Hmm.
etc. The region probably has, depends on how you count it, 120 million people with diabetes now, and this is increasing. So,
Yep.
this is increasing. So it's a huge burden, particularly in urban areas that we have studied. The prevalence of diabetes is higher than the prevalence of diabetes in, say, Indian Americans here in the United States. So at one time, Indians migrating to other countries had very high prevalence of diabetes, whereas in India,
Yeah.
the prevalence was very low, it was about 2%. So it
Huh.
was thought to be Indians going to another country and acquiring those risks.
Yeah.
But a
It makes,
recent study that one of my colleagues, Anjali Gujral, did some years ago, comparing diabetes in Chennai, India, with diabetes in Indian Americans in California and Chicago, she found that the diabetes rates were higher in Chennai, urban
how
Chennai,
interesting.
than in thing. And we find similar rates of diabetes across all major cities in India, in
Huh.
Pakistan, Karachi. I'm sure other parts of South Asia would be similar. And it's not
Hmm.
just an urban phenomenon anymore. Metropolitan cities, it's happening. And even in rural areas, you're talking of diabetes rates or a prevalence of 8%, 9%. So it's a, and even in
Wow.
in the US, for example, when I mean, a colleague of mine, she looked at 30, a sample of 30 that represents 36 million immigrants to the US, or from all different regions of the world. The people from the Indian subcontinent have the highest prevalence of diabetes compared to all ethnic groups in the United States.
Wow.
And what is
Huh.
also striking is that your normal weight South Asian, this is where it gets interesting, your normal weight South Asian has as high a prevalence of diabetes as an obese European immigrant.
Hmm.
So suggesting it may not all be obesity. So,
Yeah. That's amazing. How is diabetes different in South Asians? Sounds like, you're alluding to some differences in South Asians.
yeah, I mean, good question. I mean, traditionally, the thinking has always been, I mean, largely, when diabetes was first seen in the PIMAs as a big problem, the theory that was hypothesized at that time was populations, because of changes in lifestyle, put on vast amount of obesity, which
Yeah.
results in insulin resistance. So the insulin is not acting, and then the pancreas is not able to keep up. So that was the theory that has always, dominated scientific
Like
literature.
lifestyle factors.
Yeah, lifestyle factors, but causing insulin resistance,
Hmm.
or impairing insulin action. So that was a dominant story. And so when people studied South Asians, the prism was, oh, the rates of diabetes is high in South Asians, so it must be insulin resistance. So the
Yeah.
idea that South Asians are very insulin resistant got promoted. However, our research is beginning to challenge that notion as too simplistic
Ah,
for a couple of reasons. Number one, we are finding a lot of diabetes in Indians, even at normal BMIs, and even in underweight Indians are developing type 2 diabetes, and this is
ah,
interesting. Second,
wow.
so they are developing diabetes at lower BMIs. And secondly, diabetes is occurring very frequently in younger people. So these are two interesting observations. And then we said, let's take a direct comparison between the Pima Indians, whom I've worked with in the past, and Indians in Chennai. So,
Yeah.
so Lisa Steinmeier, my colleague, compared the two population studies.
Oh, interesting.
So when she looked at it, she found the clues that that things are quite different. I mean, for example, by age 50 or 55, let's say age 55, half the population of Pimas had diabetes, and by age 55, half the population of people in Chennai, age 20 and over, had diabetes. So
Wow. Interesting parallels.
yeah, so the both two populations is very high risk. But what
Huh.
was dramatically different was that the Pima Indians were 7 BMI units on average heavier and 25 centimeters larger in the waist compared to the Asian Indians.
Oh, wow.
So, two equally high risk populations, one relatively more obese and the other relatively less obese. So, then we said, let's look at both their insulin resistance or insulin sensitivity and their insulin secretion. And what
Hmm.
we found was stark. The Pima Indians, even your normal weight, normal glycemic Pima Indian, was far more insulin resistant than the Asian Indians, 3 to 4 times more insulin resistant. But your Asian Indian in Chennai, even a normal weight, normal glycemic, was secreting about a third to a half of the insulin compared to the Pima Indians. So this
Huh.
gave us the first clue that perhaps in Indians, yeah, there may be an element of insulin resistance, I'm not denying it, but
Yeah.
perhaps the bigger problem in Indians may have to do with an innate capacity, lack of capacity to secrete insulin.
Hmm.
So they do not have the capacity to secrete insulin. And therefore, with any modernization and little deposition of fat in the liver in particular, they
Yeah.
don't have the ability to compensate. So,
Ah,
so that may be what is happening. So essentially, we think the dominant phenotype of type 2 diabetes in Asian Indians in India or the Indian
mhm.
subcontinent is
Yeah.
probably an insulin deficient form
Ah,
where the body, the pancreas is not secreting enough insulin. And therefore, when challenged, the body does not have the capacity to make up.
huh.
And that is why even non-obese Indians quickly develop diabetes and with very little fat deposition. Whereas in the Pima Indians, in spite of much larger weights and body weight, waist circumferences,
Mhm.
they have the capacity to secrete insulin for a long, and this
Yeah.
may be true in whites, etc. So we think the primary problem in Indians is likely to be insulin deficiency. And indeed, there have been several studies since showing that there are 4 or 5 different phenotypes of diabetes, type 2 diabetes. Some of them are more of the insulin deficient variety, others are more of the insulin resistant variety. And if you look at the frequency of manifestation, all types of phenotypes of diabetes are present in all populations. So there isn't an ethnic specific phenotype.
Yeah.
What is different is in your Indian population, a high frequency of diabetes happens to be the insulin deficient variety.
Huh.
Whereas in the whites, a high frequency of diabetes happens to be the insulin resistant variety. So this is where our research is going at the moment, is to unravel the mystery of why is it there is more of insulin deficient type 2 diabetes in Indians, occurring largely in normal weight people and in underweight people and in younger people. So that, or it may also be in older people. So essentially, this is the the mystery that we are trying to solve at the moment.
That's
And
interesting. That's
we
so
have,
fascinating.
yeah.
Um, so I guess I was thinking, could this explain maybe this double mechanism, why it's more prevalent in South Asians compared to other
Yeah,
ethnicities? That's lacking in other ethnicities, for instance.
we can, there are only clues here. We don't know
Mhm.
the ultimate answer. But
Yeah.
the clues we have is number one, children who are born malnourished or undernourished,
Hmm.
maternal undernutrition are two factors that increases the risk of diabetes in the offspring.
Yeah.
So there was a famous study called the New Delhi birth cohort, which followed children from birth till age 30. So the
Uh-huh.
children that were stunted or born low birth weight, by age 30, their glucose levels were rising, and some of them were diabetic, some of them were IGT, pre-diabetic, etc. Whereas the children who were born normal weight, their glucose levels were good till age 30 and beyond. So
Huh.
similarly, there have been studies, there have been meta-analysis done from several populations indicating that low birth weight or maternal child malnutrition may be
Huh.
an important risk factor for future diabetes. So
Oh,
the
that's so
question,
interesting.
so the next question you're going to ask me is, how does that work? So this is where some of our recent work in the last 2 years is beginning to show some clues.
Hmm.
So, a colleague of mine, Dr. Al Powers, who's at Vanderbilt, runs a US pancreatic biobank. So
Hmm.
these are pancreas donations from unfortunate road traffic, victims, accident victims. So they
Yep.
study the pancreases there. So we approached a group in Hyderabad, India, the
Okay.
Asian Institute of Gastroenterology, who had, were looking at, pancreatitis related diabetes. So they had studied some of those pancreases. So we said,
Yeah.
is there any way we can acquire uh, pancreases similar from normal people? So they
Hmm.
approached a committee called the Jivan Dan Committee in India, who do the same thing. They acquire organs like kidney, for transplantation.
Yeah.
So they got the first 5 donations of pancreases. These are normal people without diabetes, people in their 40s and 50s at the most. So they followed the Vanderbilt protocol and examined the pancreases of Indians. And so when early data, this is very preliminary. So when we compared the two sets of pancreases, what we are finding is a clear picture that the pancreas of the Indians seems to have smaller areas of of the beta cells, the alpha cells, and the delta cells of the pancreas. So the areas are small. Whether
Hmm.
this means that the single cells are smaller or the total mass is smaller, these are questions we have to pursue. So we
Yeah.
are hoping to enlarge in the study and study. So the question, I think, what I'm getting at is that some level of intergenerational malnutrition or whatever insult or other evolutionary pressures over hundreds of thousands of years in the Indian subcontinent has probably impaired some of the pancreatic function, maybe in terms of less endowment in terms of number of cells or the size of cells, we don't know.
Hmm.
And therefore people have learned to adjust to a very different lifestyle
Yeah.
evolutionarily. Now when that changes, they don't have the capacity to secrete.
Hmm.
So because they don't have the capacity, now the question is, what caused this? Why are the individual cells secreting enough insulin? And if so, is there any genes involved in this? These are the interesting questions we'd like to pursue now.
Wow, that's so fascinating. Um, are there, so of course you mentioned the maternal malnutrition, low birth weight as a risk factor for diabetes future later in life. Are there any other unique risk factors in South Asians?
For diabetes,
Yeah, for diabetes.
clearly, when you look at the clearly, okay, the other problem with South Asians is that they tend to have lower lean muscle mass,
Hmm.
largely less relatively. So muscle is important for glucose metabolism. So that
Hmm.
would be one area of deficiency. The other, critically, South Asians tend to have a propensity to deposit fat in their liver, so which increases, which worsens insulin action.
Yeah.
So we think there are these three things. Number one, uh, innate deficiency in secreting insulin, for because of something that has gone wrong with the pancreas historically. We need to find out what that is. It might be
Hmm.
an evolutionary mechanism of some sort.
Yeah.
Second, low lean muscle mass, and third, hepatic fat deposition. And the hepatic fat deposition is where the lifestyle factors become important, such as diets very high in refined carbohydrates, diets very high in sugars, diets
Hmm.
poor in protein, for example, diets. Those are the kind of areas that we should investigate in terms of diet, and also lack of physical activity.
Ah,
So again, so there are two issues here. There are one set of issues which are probably amenable through lifestyle interventions or immediate pharmacological therapy. There's another set of issue which might be deeper, which might have to do with understanding the pancreas better and coming up. Who knows? There might be a potential cure for it. That
yeah.
we might be able to regenerate the beta cells. Who knows
Right.
in the future? Those are the kind of. So there are these two angles. So they keep saying there's part of the mystery we don't know. We need to get into the basic sciences to understand it better in these populations. And the
Hmm.
other part, what can we do now? So there are
Yeah.
two different questions. And this is why I'm very excited, because, South Asia, like you said, is about 23% of the world population.
Yeah.
And yet, less than 1% of research related to diabetes comes from that population.
So unfortunate.
So unfortunate. And
Yeah.
so what happens is you have all these guidelines that are developed for South Asians, which are
Hmm.
largely extrapolations of study in well-nourished Europeans or
Yeah.
people that
Right.
have, the difference is South Asia missed the Industrial Revolution, and at one time, and now they're catching up. So
Right.
as Europe, North America had an early introduction of Industrial Revolution, and there might be other factors in the evolutionary history that we need to take care of. Yeah.
Yeah. That's amazing. And I really appreciate how you actually listed risk factors, which are particularly or relatively unique for South Asians that you mentioned, including the low lean muscle mass, the diets that are higher in refined carbohydrates, and the relatively less exercise or physical activity. Um, I would also is regarding a similar condition, metabolic syndrome. Um, do South Asians also have a predisposition to that?
Yeah, firstly, the metabolic syndrome is just a
Yeah, and of course we should
concept.
define that, by the way, to
Yeah,
our
yeah.
audience.
No, I'm just saying it's just a concept. I would rather say, are they at high risk of cardiovascular disease? And that is true. South
Mhm.
Asians tend to be at very high risk of cardiovascular disease, and what we know clearly is they're at high risk of atherosclerotic cardiovascular disease.
Yep.
They may also be at high risk of myocardial, heart disease, which is, heart failure. That's an
Mhm.
area of research that has not been explored. So the question is, why might this be the case? And here, diabetes clearly is a major risk factor for cardiovascular disease in South Asians. And in
Mhm.
addition to diabetes, there are other factors such as abnormal lipids. LP little a, for example, and
Yeah.
then low HDL levels, high triglyceride levels. These are curious, haven't been well studied, but that seems to be a phenomenon of South Asians. You take a South Asian person, they tend to have high triglyceride levels and low HDL levels, and they may
Mhm.
have so lipids. The lipid abnormalities is one thing you should worry about. South Asians also tend to have higher blood pressures. Is that because of high salt intake? Is it because of something else? So those are kind of questions we need to ask. There might
Ah,
be other unexplored factors. So the combination of diabetes, high blood pressure, dyslipidemia, and dietary factors, activity, loss of physical activity, greater sedentary behavior, and increasingly there are also data about stress and heart disease, and stress and so whether these are all issues that need to be brought together.
Hmm.
But all we know is that there are very few studies that have directly studied South Asians carefully. And so this is where we are trying to push the work that we are doing at the Emory Global Diabetes Research Center to, in a more organized way, to study the problem in South Asians.
Yep. Excellent. Okay. Um, how about are South Asians at higher risk for strokes and kidney disease?
Kidney disease, definitely. And again, a lot of the kidney disease is related to diabetes. People with diabetes are at high risk. But also, it's difficult. For the few studies, starting from Sri Lanka, some in Pakistan, there are also some data suggesting certain parts of South Asians may have what's called chronic kidney disease of unknown etiology, whether it's because of toxins or pollutants or arsenic. We don't know what it is. There are several factors that are being postulated. But yes, South Asians are at very high risk of kidney disease. Strokes too, they are at high risk of stroke.
Hmm.
Particularly, there's been some data on hemorrhagic strokes. It tends to be higher, and it may be
Huh.
higher in South Asians. So too thrombotic strokes. So yes.
Yeah.
So this entire, if you take the whole area of cardiometabolic diseases, South Asians are at very high risk. They are in fact at much higher risk than your Chinese population or your
Hmm.
African American population, etc. So yeah.
Okay. Another question. I think you actually, some of my questions you already answered. What are some specific ways that South Asians can prevent the development of diabetes? Specific dietary recommendations that you would, for instance, suggest?
Yeah, absolutely. I mean, you might know that some 20 years ago, there was this classic study called the Diabetes Prevention Program, the DPP trial.
Hmm.
Actually had its origins in some of the early work that I did with the Pima Indians, the lifestyle intervention, and my
Ah,
mentor Bill Noller, and I, in several of us, we designed what eventually became the diabetes prevention trial. So in
yeah.
that trial, all ethnic groups in the US were recruited, and these were people with IGT, but who were overweight. So the average BMI was 30 and above. So
By the way, IGT, impaired glucose tolerance, is that
yeah.
okay?
So
Okay.
what IGT is, it's pre-diabetes.
Okay.
So your glucose is normal,
Hmm.
but when you're challenged with the glucose with 75 grams of glucose, your 2-hour glucose goes higher than normal, but less than diabetes. So it's between
Okay.
140 and 200. So
I
it's a
see.
kind of a risk factor for future type 2 diabetes. So
Uh-huh.
in that trial, people with that pre-diabetes and who are obese, who had BMI of 30 and older, were recruited, and 24 sessions of lifestyle intervention was delivered. It was 16
Oh.
weekly sessions followed by 8 weekly maintenance sessions, and there was a 58% reduction in progression to diabetes in that
Oh,
trial.
wow, very impressive.
Okay, so the question was, can such a trial be taken, adapted to South Asians? So that's what we did. We took the trial, took
Hmm.
all the toolkits, and we adapted it to South Asians, and we repeated the trial in Chennai, India. And there have been one other similar trial. But what we
And
have
what is
found,
that trial called?
it's
Would you
called the
say
It's called the DCLIP,
declip? Okay.
called the DCLIP trial, and Mary Beth Weber is the first author on the papers that were published from the trial.
Okay.
So what we find there is that lifestyle interventions work in Indians also who are pre-diabetic, which here we expanded pre-diabetes because the dominant form of pre-diabetes in Indians is not your impaired glucose tolerance, but it's impaired fasting glucose. So this is another important thing to note. The major glucose abnormality in South Asians is high fasting glucose.
Ah,
High fasting glucose is driven by two factors. It's driven by poor insulin secretion or beta cell function and hepatic fat deposition or hepatic insulin resistance. So it's a different, this is where there's a different pattern. So when we
hmm.
repeated the trial in Chennai, including this broader spectrum of pre-diabetes, we found it was effective but half as effective as what we found in the diabetes prevention program. So
Ah,
lifestyle intervention works in Indians, but about at half the efficacy or effectiveness. Okay. So now the question you're asking me, what did we include in the lifestyle intervention?
yeah, exactly.
So very simple. The simplest thing would be physical activity. Walk at least 30 minutes a day, every day. And so walking is enough. Brisk walking is enough. But
Yep.
in addition, now we're beginning to, if we were to revise this, we might add some weight training, some resistance training, because South Asians tend to have low muscle mass. But again, a
Ah,
trial has not been properly done, but that's
yeah,
might be an important component to use. So those are two aspects of exercise you can introduce, brisk
yeah.
walking or regular physical activity, less sedentary behavior, less television watching, maybe,
Hmm.
and then maybe weight training, maybe just dumbbells 2 3 times a week, 10 15 minutes, just trying to give some
Okay.
broad thoughts. That's one thing clearly people can do. The other, in terms of modifying diet, I mean, clearly the biggest culprit in the South Asian diet tends to be refined carbohydrates. Like,
Mm.
for example, in Chennai, 70% of the energy intake comes from one substance, white rice.
Yeah.
So even your wheat-based products tend to have a lot of maida and a lot of, starch in it. So can
Hmm.
that be changed? Can we replace white rice with brown rice or high fiber
Yeah.
bread, etc.? That's one area.
Yeah. And
Second,
as just an aside, I would just also add that I discovered that white rice was not even in existence in the Indian diet until the 1800s, late 1800s, late 19th century, because rice milling was not invented.
you're absolutely correct. I mean, the thing was this, like the argument I often run into was, my grandfather also ate rice. Why are you telling me my rice is bad? But your grandfather ate a different type of rice. It was
Yes.
not polished. It was with all the husk.
Yep.
It was rice of high quality, in
Yep.
terms of nutrition. Whereas the rice that you're eating now is polished, it's refined, it's taken out all the vitamins, and it's very high in glycemic index. Okay, so one
Yeah.
area could be reduce the amount of refined carbohydrates, and the other culprit for refined carbohydrates is your sweets. I mean, our South Asian
Yeah.
sweets are delicious. I have a weakness for all of them, but
Right. Definitely.
a laddu or a rasmalai or a
Gulab jamun.
jalebi or a gulab jamun,
Yeah.
or a carrot halwa,
Right.
whatever it is. You think of any major feast in South Asia, regardless of what religion, it doesn't matter.
Mhm.
This sweets, high carbohydrate sweets are and they are very addictive. You can eat a lot of them very easily. Okay, so
Yep.
sweets, sugar, cutting out sugar. Could you cut out sugar from coffee, from tea, perhaps? Or, for example, like, for example, if you have 4 times 5 times coffee in India, those are the kind of people drink a number of times, and you're adding a spoon or 2 spoons of sugar each time. It all adds up. So these are
Yeah.
some simple places that you can start modifying your diet.
Hmm.
And then, what about protein intake? Our protein intake is low. So can
Yeah.
we increase our protein by better quality dal, maybe some tofu in it, maybe a little bit of low fat paneer, if such, if it can be done. So can you increase the amount of protein? And the other advantage of increasing protein is that it improves satiety and may make you less craving for carbohydrates. So you're kind of a good replacement, if you like.
Ah. Yep.
So, and then fruits and vegetables. So, our diets are notoriously poor in vegetables, although a high proportion of Indians, the 30 40%, are supposedly vegetarians. And even the takers are low meat eaters. I mean, but the problem is, whatever vegetable is eaten is overcooked, it's fried, it's
Yeah.
soaked in oil. So, can you cook that differently, in terms of, can you increase the amount of vegetables in the diet, particularly
Hmm.
fresh green vegetables, mildly cooked vegetables, and good fruits, like guava, melons, etc. Can you increase berries? Can you increase that kind of a diet? So I keep saying, what you need is a Mediterraneanized Indian diet, but Indian in character.
Yeah.
For example, in the last 20 years, in my own home, we have revolutionized our cooking. We eat Indian food very often. My mother lives with me. She's 85 years old.
Hmm.
The way she cooks it is very different. I mean, for example, she boils the vegetable, garnishes them, and then you put it down and then add olive oil on top for taste. So we,
Ah,
we don't fry, at all.
oh,
And
interesting. Okay.
all our rice tends to be brown. Our breads and chapatis tend to be really high in fiber. We
Hmm.
tend to eat more fruit, more vegetables, more fruit, and we have increased the amount of proteins. And I swim on a regular basis. I swim almost every day, so that's been my physical activity. One
Ah,
thing I'd like to do is, lift some weights, but I haven't. I do that
yeah.
occasionally, get bored about it. So I think, and then the other important risk factor that we should pay attention to is sleep. I mean, sleep
Hmm.
may be a very important risk factor both for glucose regulation, dysregulation, and for cardiovascular disease.
Yeah.
So, getting sleep right, 7 to 8, 7 hours of high quality sleep right, being taking a more of a Zen approach to life, keeping stress away. Those, and again, my colleagues Viola Vaccarino and Arshad Koyumi have been studying the role of stress, and they seem to affect certain important cells in the body, like the pluripotent, cells, etc. So there is a lot of connection between cell and and stress and biology, which is
Ah,
understudied. So when you take
wow.
all this into account, so what you're basically talking about, a diet that is physically, you're physically active, a lifestyle, a certain amount of weight training or resistance training, lower your refined carbohydrates, cut out sugars to the maximum possible extent, cut
Yep.
out fried food, cut out saturated fat, replace it with monosaturated fat like vegetable oils or olive oil, for example. Increase
Hmm.
the amount of proteins in your diet.
By the way, how
Um,
can you do that? Sorry to interrupt. How can you increase protein if you're vegetarian? What would you suggest? Because
I
of
mean,
course,
the sources of okay, this is another interesting question. There are a lot of synthetic proteins that are useful. I mean, clearly, even in diet, okay, the pulses, the dals, depending on the type of dals, they have reasonable amount of protein. And if you're happy to eat eggs, egg white is a rich source of protein.
mhm,
If you're ready to eat eggs, or paneer is a good source of protein, but you end up having high saturated,
yeah.
you tend to saturated fat. Tofu, if you can tolerate tofu tends to
Hmm.
be. So I think
Okay.
there are interesting ways of increasing protein, but I
Excellent.
think the majority of South Asians don't get enough protein. That's the.
Yeah. All right. That's a great, those are great suggestions, Dr. Narayan. Um, Another question, how about, I think you sort of mentioned this, but what other, of course, you mentioned lifestyle changes already, sleep, reducing stress, getting enough physical activity, including, exercise, specifically resistance exercises, and of course, brisk walking at least 30 minutes a day, and then resistance exercises, you were suggesting like around 15 minutes at least twice a week, which includes lifting weights. I wanted to ask, any other lifestyle changes for South Asians?
For example, I mean, okay, I think avoiding snacking is a good idea. We often
Oh,
snack
okay.
when we're stressed, okay, because that's a good idea. You can cut off things. And the other, can you cut down on portion sizes?
Hmm.
Okay, so these are simple tips. So between all of this, the trick is this: the reason it took 24 sessions to help people to modify their behavior is it's not easy. So you don't want to implement all of this in day one.
Hmm.
You probably want to do it incrementally. You might say, okay, this week I'm going to start walking 30 minutes a day. Okay,
Yeah.
fine. So next week, okay, I'm going to shift from white rice to maybe brown rice. Okay, so you slowly build up things, and before you know, you've acquired a new taste and you start feeling different.
Yeah.
And I think these are some things that you can easily do. And maybe the other thing is South Asians tend to be more communal than
Hmm.
in their way of life. So we eat together with others. We invite people. The only thing our famous form of recreation is invite people for meals.
Yep.
When a guest comes home, you have to feed them well. When a
Right.
woman is pregnant, you have to feed her well.
Hmm.
Every festival is full of food. We're a foodie culture.
Yeah.
So,
Yeah.
so changing some of those norms, I think families need to work together. It'd be very awkward for one person to follow a healthy lifestyle where three others in the family are not. So, can
Yeah.
we make family level lifestyles? And the bigger question is about our children. Like in the US, not just South Asians, but in the US as a whole, by age 19, 50% of the population is overweight.
Yeah.
Means, and we are finding that a lot of the factors leading to overweight and obesity happen within the first 5 years of life, which means the pregnancy environment has to be well managed. You've got to go into pregnancy in healthy with healthy lifestyle, and the first 5 years of life is very important. How you bring
Mhm.
up the child, etc.
Well, those are great suggestions. I have, okay, how about any special considerations for South Asian women?
Good question. I mean, one of the factors, I mean, in India, for example, South Asian women uh, appear to have higher prevalence of diabetes in South Asian men, particularly adult women. And we think a major factor may have to do with there are two potential factors. One, women have babies and then
Mhm.
don't gain weight during pregnancy and then don't shed it. So
Uh-huh.
if there is one thing that can be done is to go into pregnancy with an adequate lifestyle so that you avoid what's called gestational diabetes during pregnancy, because that gestational diabetes or high glucose during pregnancy not only increases the risk of the woman's diabetes in the future, but also increases the risk of the unborn child's diabetes in the future.
Yeah.
So, a mother remaining healthy in terms of following a good lifestyle during pregnancy is important. And then postpartum, getting to shed the weight that you've gained during pregnancy is very important. And again,
Mm.
that doesn't happen enough in the Indian subcontinent. Again, when you look at gestational diabetes, the population with the highest prevalence of gestational diabetes is again South Asians in the United States. So, and
Uh,
again, here too, there might be these two factors. There might be some South Asian women developing diabetes during pregnancy because of the excess weight gain. There might be others who are developing diabetes during pregnancy because they have innate poor insulin secretion to start with.
hmm.
Pregnancy is an insulin resistant state, so the combination
Yeah.
might bring it out. So that is one thing. The other is about cultural issues. I mean, whether women's propensity to socialize or to, I mean, many families are patriarchal, whether the best highest quality food is reserved for the men. There are all these interesting questions which we don't know, but in
Yeah.
general it is very important uh, for women to go into pregnancy with a healthy lifestyle, and also to shed the excess weight post pregnancy and maintain their lifestyle in ways that is important.
Hmm. That's really one other aspect I've been hearing about is polycystic ovarian syndrome. As for our listeners, that's a syndrome that is associated with infertility, uh, irregular menses, hyperandrogen levels with hair loss, male pattern baldness can occur, and also other things like depression and anxiety. How about, I mean, I'm hearing that may be an issue in South Asia when it's potentially more prevalent than in other ethnicities.
Yeah, we don't know. I mean, again, it is a state of insulin resistance. It causes insulin resistance and can be related to diabetes. But whether truly it is any more frequent in South Asians than in others, we don't know. I think formal, well organized studies have not happened. So
Okay,
I would hesitate to comment on it.
okay, I see. Okay, and how about South Asian obesity? How is that different? And what is its role in diabetes?
Yeah, people have brought this up. I mean, so it tends to be the typical South Asian body habitus tends to have, fat deposition around the waist, okay,
Mhm.
and less muscle mass. So they have smaller buttocks, smaller legs, thinner hands, thinner, frame in general, but
Yep.
more fat deposition around the center. So the thing has always been central adiposity or central weight gain. Does it mean there are more, fat being deposited in the organs? So that has
Yeah.
been the question. But interesting, and that has always been the convention that South Asians have more visceral fat or fat around organs. So that has been studied recently in a systematic review in England, which has still not been published. They compared fat deposition, body distribution, fat distribution of whites with comparable South Asians,
Yeah.
And the bottom line is, for the same BMI, South Asians have more fat. There's no question about it. Okay, for the
Mhm.
same BMI.
Okay.
But where the fat is what is interesting. South Asians tend to have more fat subcutaneously, in beneath the skin, and also more fat in the liver in comparison to the whites. The overall fat around the other organs tends to be roughly similar between South Asians and white,
Ah,
according to this latest meta-analysis is not
okay.
being published. Again, but the bottom line is, yes, for the same weight, for the same BMI, South Asians have more fat, have less lean muscle, and yeah, that's the point. So they have less lean muscle and more fat, which
Huh.
is where the problem is, and more of the fat tends to be around the waist.
Interesting. Okay. Um, and is there any other testing that South Asians should be undergoing to help diagnose this early
Yeah,
before they develop,
this is a
symptoms or frank diabetes, or what
this
would you
is a
suggest?
very good question. I mean, the standard tests that are recommended by the guidelines today are for diagnosing diabetes or pre-diabetes are your fasting glucose, or a glucose tolerance test which gives you a 2-hour glucose, or a hemoglobin A1C. All of these are useful, but we are arguing that these may not be enough for South Asians for several reasons. I mean, like for example, the A1C levels may be artifactually higher or lower. It's possible. There are
Ah,
several
interesting.
factors. Okay, and there are arguments that it may be actually higher than normal in certain groups. Because of other factors. But more importantly, remember I told you that a major factor in South Asians, or at least in the dominant form of diabetes in South Asians, may be poor insulin secretion. And
Yep.
we think it may be the first phase insulin secretion. So when you have a meal or you drink glucose, within 10 to 15 minutes, your pancreas is pushing out insulin, a
Hmm.
big spike of insulin. We think that is impaired in South Asians. That
Ah,
capacity is impaired in South Asians. And you don't pick that up from measuring a fasting glucose or a 2-hour glucose. You probably
interesting.
you probably need to get a fasting glucose, drink your 75 grams of glucose, and then measure a 30-minute glucose. So
Oh,
we are
wow.
finding there's a significant number of people who have normal fasting glucose, normal 2-hour glucose, but elevated 30-minute glucose, which might be important in South Asians. Again, this test has not become common practice. It's more a research tool,
Hmm.
but this might be something we should start doing.
Well, now nowadays there's more continuous glucometers available that you may be able to detect that. Uh,
But I think that's again is a good question. I think
mhm.
that's again it's used more in management of diabetes,
Yep.
where the continuous glucose monitoring, which is which you put in a sensor, it
Yep.
measures your glucose on a regular basis. So you might be able to see the patterns of glucose
Uh-huh.
and modify therapy accordingly. But
Okay.
but to diagnose who's at risk of developing diabetes, or
Yeah.
whether they have a pre-diabetic phenotype, I think those studies have not been done. I think we need to extend
Right.
evaluation of glucose monitors, continuous glucose monitors in normal people, in pre-diabetic people, to see what normal patterns or differences in patterns exist. These
Hmm.
are all questions for the future.
Yeah. No, definitely. Okay. Now, how about what can South Asians do after they've developed type 2 diabetes? Is there
Oh,
any?
a lot,
You
a
might have,
lot.
of course, alluded to some of this already, but I was thinking if there's anything else that people
Well,
can do.
there is a lot. I mean, in fact, paradoxically, one of the great things that have happened in the last 20 years, particularly in high income countries, okay, in South Asians living or any populations living in England, in US, in Europe, etc., Singapore, is that we have we are doing a good job in terms of controlling diabetes and its complications. Okay, so, for example, it's comprehensive care. I mean, clearly, somebody with diabetes needs to follow a good lifestyle, things like physical activity and diet that I mentioned.
Hmm.
Then, in addition to that, glucose control is extremely important. Keeping glucose levels as monitored by an A1C, below 7.5, 7, I think that's kind of thing, it's
Yeah.
extremely important. Keeping blood pressure well controlled. And in fact, people with diabetes, the recommendation is to keep the blood pressure lower than for a non-diabetic person. So the recommendation would be even 110 or 120, 110
Yeah,
systolic, say 70
that,
diastolic. And then keeping your lipids or your LDL levels low with statins. Use of aspirin, yes and no, there are questions about it, but that again has certain benefits. And in
mhm.
addition, regular eye examinations, foot examinations, dental examinations, and getting your kidney test, urine tested on a regular basis, and,
Ah,
and use of kidney protection drugs like ACE inhibitors, ARB. So this entire package, can reduce the risk of complications by 60% or more. So I think this is extremely important. And this is actually happening in several populations. And in fact, in the UK, there was a study published where not only is diabetes control higher, better, but the risk of death in a diabetes person doesn't seem to be any higher than a
mm.
non-diabetic person because they are well controlled. So, so these are
And
all
this is
important.
applicable, of course, to South Asians also.
It is applicable to South Asians. But the problem in South Asia is that the quality of diabetes care, except in some excellent places, tends to be not good. And I think this is where, and if you think of quality of diabetes care, a lot of it is organization of care. It's less about great doctors, but it's more about good organization. Like for example, we did a trial called the CARS trial in 10 centers, 9 centers in India and in Karachi, Pakistan. We
Huh.
randomized 1,200 patients. One group of patients, half of them got regular care like they were getting usually. The other half, we put in two small tools, a decision support software with guidelines put into it. So that would spit out information on to the physician on what needs to be done and send out reminders to the patients on what needs to be done. And then we had community health workers, who would motivate patients, or the ones who are having difficulty controlling. They will go to their home, counsel them, etc. So the group with these two interventions did a lot better, and at
Mm.
2 years, at 2 years, had better control of glucose, better control of blood pressure, better control of lipids, and we are now following up this cohort to see whether it's reducing diabetes complications, and we think it might be.
Oh,
But
that's a great intervention there.
yeah, and this is
Um,
it's a simple intervention. It's low cost. It can be put in place in any hospital system, in the primary health care. We should remember that 90% of diabetes is cared for in primary care.
yeah, that's another question I was wondering. Are South Asians more prone to complications from diabetes, than other
I
ethnicities?
mean, there are people have suggested that South Asians may be at higher risk of certain types of like kidney disease.
Hmm.
Some people have said they've less of retinopathy, but again, these are not studies that have been formally done. These are not
Yeah.
head-to-head comparisons. There might be a lot. So I would not is that young people developing diabetes are at higher risk of complications than diabetes occurring at later ages. So
Hmm.
the youth onset diabetes, particularly diabetes occurring before the age of 40,
Yeah, and
the
you're
risk
talking
of
about type 2 diabetes. Of-
hello, yeah, you said
Hello,
type, yeah, yeah,
are you
yeah,
still there? Okay, I
yeah,
think it just sort of cut out for a second.
yeah.
Um,
Yeah, I mean, I said the risk of complications is higher in young onset type 2 diabetes,
okay,
than in older onset type 2 diabetes. Yeah.
got it. Okay, well, that's very important to know that. Um, and then my final question is, what do you feel about the role of metformin to treat pre-diabetes or to prevent, diabetes
Yeah. Metformin was
or
one of the
pre-diabetes even?
Metformin was one of the drugs that was tested for prevention of diabetes in those with impaired glucose tolerance in the diabetes prevention program.
Yeah.
It had benefits. So in people who have impaired glucose tolerance, okay, and after you've tried your lifestyle intervention, there is a role for adding metformin. That's what we did in the DCLIP trial.
Yeah.
Or, you can add it independently. But metformin may not work that well in people with the fasting glucose type of prediabetes, the impaired fasting glucose type of prediabetes. Okay, so this is
Huh.
another place where we think newer trials are needed for what are the right pharmacological interventions for
Yeah.
the insulin deficient or the high fasting glucose type of diabetes in South Asians. I mean, maybe your DPP4 inhibitors, maybe your SGLT2 drugs. So some of those may play a bigger role, I think, but the trials need to happen.
Okay, so basically metformin can be helpful, but not if you have an impaired fasting
Fasting
glucose
glucose. No, it
due
doesn't
to
seem
the
to. It doesn't
reduced
seem to.
beta cell
Yeah,
activity.
it doesn't seem to be. Although it is
Huh.
recommended, it may not have its same effect. Whereas in those with impaired glucose tolerance and those who are obese or overweight, it definitely has high effectiveness.
Okay. All right. Well, great. This has been a great session. It's extremely informative, very enlightening, and very eye-opening. I really, really appreciate your time, sir, and thank you. I was very honored to have you here with us. So everyone, thanks for joining also and listening. This is the end of today's program, Expert Spotlight for South Asian Heritage Month. Do you have any final words, Dr. Narayan?
No, I mean, all that I can say is that given current knowledge, there's a lot that can be done to slow down progression of towards diabetes or to prevent diabetes, and definitely a lot that can be done to prevent diabetes complications. And I think we should take that very seriously. But there is a huge need for more research in South Asian populations. And I think there's a huge paucity of good research, and that gap needs to get filled.
Definitely.
Thank you.
I really, really appreciate those words of wisdom. Thank you so much, sir.
Thank you. Thank you.
Yeah. Bye.